want to thank everyone for joining us today to celebrate this critical federal investment in the work of confronting the public health crisis that is structural racism and in combating substance use disorder and homelessness in the city of Boston. Of course, I want to thank Mayor Wu for joining us and Commissioner Ojekitu for hosting us this morning and for being incredible partners in this work and in the work of really empowering community every single day. I want to also thank our partners in healthcare and in substance use disorder services for joining us today and for your year-round, the work that you do year-round, the work of healing and of our collective public health. I'll be brief in my remarks, not only because I'm battling laryngitis, but because we want to have a free-flowing conversation about the impact of this grant, as well as the work that we have before us as policymakers to build healthy communities and to make sure that everyone is safely housed and on a pathway to lifelong health. Today's announcement is really an example of something that I characterize as cooperative governing. It's the best sort of partnership. Those things that are community-driven, government-endorsed, and invested in. The Boston Public Health Commission, the Mayor of Boston, our esteemed partners here, are leading, innovating, and thinking about big ways to address systemic issues like homelessness, addiction, and structural racism. I want to applaud the Biden administration. I think in order to be an effective lawmaker at the most basic level, it's our job to center the humanity and dignity of people and to solve problems. And I believe to do that, to advance legislation that is responsive. And so I want to applaud the Biden administration, the Department of Health and Human Services, and the Office of Minority Health for being responsive to our advocacy and modeling this grant after a bill that I introduced in partnership with Senator Elizabeth Warren and Congresswoman Barbara Lee, and that is our bill, the Anti-Racism in Public Health Act. This grant, again, is responsive in many ways to what was outlined in that legislation, and so I thank the administration for being responsive. Our bill, the Anti-Racism in Public Health Act, would confront structural racism as a public health crisis through two bold new programs within the CDC, including a grant program to expand research and investment to address the public health impacts of structural racism locally. And the grant program at HHS, under which this funding was awarded, again, was inspired by one of the programs called for under our larger bill. So in order to apply for this grant funding, municipalities and organizations have to demonstrate a commitment to identify new and innovative ways to address policies that may create or perpetuate health disparities and may contribute to structural racism. I think this is well-timed, certainly long overdue, but it's well-timed in that we have many times we've said and heard others talk about that the pandemic has laid bare every inequity, every disparity, racial injustice, and worsened it. But I think we find ourselves at a moment and we have to ask ourselves the deeper and more important questions. Well, what are we going to do about it? Our response cannot be just to default to a pre-pandemic unjust status quo, because that would be to be complicit in those inequities and disparities that have persisted for so long and have been exacerbated. And so we have to be legislatively and from an appropriations and budgetary standpoint disruptive and actively anti-racist. And that's true across all policies, but including and especially public health. So I'm so proud that the City of Boston and the Boston Public Health Commission were one of 10 organizations nationally to receive the community-driven approaches to address factors contributing to structural racism and public health initiative. Say that fast 5 times. Grant funding. Okay, we should just call this grant Do Big Things. So this is yet another testament to the City of Boston being a national pace setter, which is exactly the role that I believe that we should be playing on all fronts, but including and especially public health. And I really do believe it's a critical step forward in addressing the cycles of poverty and trauma that have trapped our neighbors, our loved ones, in the throes of addiction and homelessness. However, it is only a first step, committed to continuing to advocate at the federal level for investment in the local solutions and approaches that match the need on the ground and that municipalities know best. That was a key component to our bill, the Anti-Racism and Public Health Act, in that I did have an incredible tutelage in education, serving on the Boston City Council for 8 years, being the founder and chair of the Committee on Healthy Women, Families, and Communities, really highlighting that the health of the individual, the family, and the community are inextricably linked. So we work very closely with the commission. And it's so important that we not have a one-size-fits-all approach, and that we empower municipalities and public health departments and community-based organizations that are trusted voices and know how best to engage, empower, and reach impacted families and community members. And so in that vein, I would like to ask our esteemed participants to introduce themselves and share any opening remarks before we jump right into the public health discussion. So we'll begin with my table mates here, with the mayor and the commissioner, respectively.
Thank you so much, Congresswoman Pressley, and it's an honor to sit at this table with these amazing partners and leaders and community advocates who every single day think about not only how to respond to immediate needs, but to change the system and build the infrastructure that we need so that we will be on a different trajectory moving forward. I want to echo the thanks and highlight that we wouldn't be here today without the leadership and vision of the Congresswoman alongside Congresswoman Lee and Senator Warren for ensuring that this landmark Anti-Racism and Public Health Act set a mark, planted a flag, and now has resulted in direct resources to our community. This is a movement and a push that the Congresswoman has championed since her time in Boston serving on the council, and we love to see that municipal affiliation continue to bear fruit for our residents and community members in the Massachusetts 7th. It also empowers agencies like the Boston Public Health Commission and our counterparts across the country to really dig up the roots of structural racism, which is the foundation for all of the health inequities and public health challenges that we have been watching grow. Of course, this group doesn't, the folks at this table will speak to this in much more depth and expertise, but it's important to always start by remembering where we are today, and that today in the healthcare mecca of the world, in the place where patients from all around the planet come to receive care, we still see tremendous gaps right for our own residents that continue to highlight racial disparities and economic injustices as well. Patients of color receive less effective and less compassionate care than white patients, and this weight and strain of racism on people of color continues to be measured and captured in the data in terms of mental health and physical health metrics. And so this funding that is going to deliver nearly $500,000 to the Boston Public Health Commission under Dr. Ojikutu's leadership will ensure that we can continue pushing for the mix that I think we've already seen delivering results in Boston, to push for new big ideas that really show the potential and possibility of making a difference when we decide to get at the root causes of challenges. I know we'll talk a little bit more about the overlapping crises of mental health and homelessness and substance use, very close to here geographically as well, but also to just get our services out into community. We, at a time when nationally we see weaponization politically of vaccinations and the pandemic and pandemic response, here in Boston, Dr. Ojikutu just led several vaccination and booster clinics where we had hundreds of people lined up in Franklin Park for White Stadium, and we were trying to just speed up the line as quickly as we could. We saw community health fairs in Harambe Park and across the city where it was get your booster, get this information, meet a clinician, connect with resources, and do some wobble in between, right? Get a burger. So this approach of really getting out in community is what these funds will enable us to keep doing, and I'm so grateful for your advocacy and leadership, and really thankful that we have Dr. Ojikutu at the helm here in Boston.
Good morning, everyone, and thank you all for being here. On behalf of the Boston Public Health Commission, I want to first thank Congresswoman Pressley for her leadership in addressing racism as a public health crisis. And I also want to thank Mayor Wu for her ongoing support and commitment to addressing so many challenges here in the city of Boston that relate to the work that we will talk about a little bit more, but particularly in addressing challenges facing people living with substance use disorder and unsheltered status in our city. Sometimes I like to start with definitions because I think this grant is so very focused in on structural racism. We don't always, pay attention to what that means. Structural racism is the way in which public policies and institutional practices perpetuate racial inequity in our world. For me, I like to say it very simply and say it's about hierarchy. It's about privilege and it's about power that excludes non-white individuals. And it manifests as systems failure. And I think all of our partners here will talk about that systems failure. So failure in our healthcare system, failure in our criminal justice system, failure in our educational system, leaving so many people behind, and failure in our housing system, which is what this grant is really going to focus in on. So here in Boston, we're addressing substance use disorder and homelessness in public health oriented ways, in ways that are actually humane, and ways that acknowledge that housing is a first step for many people. It needs to be a first step for many people, and then there are many steps beyond that on a path to recovery. We're taking this very seriously. So starting in December of 2021, we implemented a plan to move people who are on the street, not more than a block or two from right where we're sitting, from tents into homes. Transitional housing, which we call, low threshold, because it's for people who don't necessarily have to stop using. They still have substance use disorder, but they have a home, they have a house, they have a place where they can sleep at night. And that's been critical. So since that time, 417 people have entered low threshold housing, and we currently have about 189 who are currently housed. And this is really a critical thing. I want to say this and really highlight the point that this is novel. Other people around the country aren't doing this, at least not at this scale. And I do really commend the commitment here in Boston to move this forward. I want to say a little bit about race and racial inequity. Baseline data from those individuals who we initially housed, 22% identified as Black, 35% identified as Latinx, so about 57% were people of color. And in more recent data here that we've acquired from folks who are out living on Massachusetts and in that area, we've seen an increase in the number of people of color who are actually out there and who are suffering. Because we know there's this long history of inequitable access to substance use treatment, housing, prevention services, we really feel that this grant is going to move things forward. And we're going to use this grant to ensure that there is equity in how we proceed with this particular initiative, the low threshold housing, as well as other work that we're doing around the city. So this grant is 3 years long, and what we plan to do is ensure equitable access to low threshold housing going forward. Critical as we move forward in this initiative. We're going to ensure equitable access to substance use services at the low threshold housing site, so people aren't just getting housed, they're getting wraparound services, they're getting case management. We're going to hire people who are of color, who have cultural and structural competency and linguistic concordance with providers. We're going to ensure community engagement, because this doesn't just affect the Massachusetts area, this affects communities all around Boston. We're going to engage the criminal justice system. Reentry pathways oftentimes lead to homelessness, so it's really key. And then I just want to say that we're not only focused in on this quarter-mile radius around Massachusetts. This is about all of Boston. We want to make sure that we are providing these services to everyone, not just about the people who are there. And I also want to say that we're documenting and disseminating this information. We want to be transparent about what's happening, and we want to engage people in these discussions because it's so critical for all of us to be at the table. So I'll stop there, and I just want to thank again Congresswoman Pressley as well as Senator Warren for their efforts to make this grant possible. It's really been incredibly key, particularly to benefit our most vulnerable residents.
Great, thank you, Commissioner.
Sure. So my name is Wendia Rodriguez, and I'm the program manager at Mass General Hospital. I'm also a person in long-term recovery, and for me that means I get to sit at tables like this. It's so wonderful to hear about this bill and what it can possibly do. My passion right now is looking at the intersection of substance use disorder and race and how that affects people. I've been a recovery coach also for a long time, and one of the things that always struck me was seeing people who go into treatment, people of color go into treatment and then have to face racism while they're getting treatment. And that has always been something that I really want to address. And, hopefully part of this grant, we can start to look at that.
Thank you.
Terrific. Hi, everybody. I'm Dr. Miriam Kamarami. I'm the medical director of the Grayken Center for Addiction at Boston Medical Center. I really want to thank you, Congresswoman Pressley, for shining this light on the need for public health level interventions to address systemic racism and helping to provide the resources to allow that to happen. I think the partnership with the City of Boston is ideal because that's what this administration has been all about. Mayor Wu and Public Health Commissioner Ojikutu have, for the first time, said the solution to people living in encampments unhoused needs to involve housing that works for those individuals. And combining that with wraparound treatment services is an incredibly powerful model. We often hear that people who are experiencing homelessness don't want to be housed, that they like living on the street, and yet no folks who have come out of the encampments and gone into the housing that we're operating at the Roundhouse in collaboration with the city, no one has chosen to leave and go back to the street. Everybody wants a safe place to live with dignity, and that can be a platform to then engaging with treatment services and kind of getting a handle on all of the issues that combine to cause real challenges for our patients. At BMC and the Grayken Center, we've engaged in a project to specifically ask the question, how can we make addiction treatment services more appealing and effective for Black people? Throughout my career in addiction medicine, I've seen the impact of systemic racism riddled throughout the experience of people of color, whether it's the trauma, the violence, the increased risk of incarceration that may be involved in setting people up to develop a substance use disorder, inadequate access to treatment that is inequitably distributed, and then, unfortunately, bad experiences during treatment in many ways. And there's so much work that we need to do there in order to address that, and we need to start by being humble and standing back and asking the question, what will make a difference? How do we address this? So we've had a wonderful experience bringing together experts in addiction treatment, researchers, clinicians, and people with lived experience, Black people who have experience with substance use disorder, who can inform us about their experiences. So we've been holding day-long convenings with these groups and having a day of structured discussion around this that's been incredibly revealing. And I'll say we have a lot of work to do to earn the trust of our patients of color, think about how do we tailor treatment so that it's culturally adapted and appropriate, make the services available in combination with services to address issues of homelessness and poverty and so on that stand in the way of people recovering. And it's been incredibly exciting to feel the partnership with the city, to feel like we all have the same aim, to address these things from a public health and treatment-centered focus and really help people make changes to improve their lives. So we're so appreciative.
Thank you. Thank you, Jibo. Thank you all. I already have a lot of questions, but I'll temper myself. Okay. Yes, Doctor?
Thank you. Good morning, everybody. I'm Dr. Denise De Las Nesses, and I'm Chief Medical Officer at Boston Healthcare for the Homeless Program. So delighted to be here. Thank you so much for the honor. Congresswoman Pressley, Mayor Wu, Dr. Ojikuto, I think it's just absolutely fantastic that we are shining a light on the fact that structural racism is a public health emergency. It is a public health crisis. Many of us in public health and in medicine have known this for a very long time. We see it on a daily basis on the faces of the patients who we care for. And in fact, at Healthcare for the Homeless Program, every day we are caring for individuals who are at the intersection of homelessness, of racism, of structural racism, and also of addiction. On our part, at Healthcare for the Homeless program, we strive to provide not only the highest quality care for our patients, but also the most equitable care. And we do that we strive to do that by provision of low threshold services and designing innovative services with all patients, including patients of color, in mind. We have a very robust consumer advisory board that really helps vet all of our initiatives. And I will say that our patient population is struggling incredibly, as you could imagine. So there is a high prevalence of what we call comorbid disease for our patient population, which is a layered chronic medical diseases on top of behavioral health diseases, on top of addiction. And then add on top of that the trauma of day in and day out, not having their basic needs met, housing, having to deal with food insecurity, and then also structural racism and the weathering that accompanies that.
That's
the
right.
stress that accompanies day in and day out being subjected to the indignities of structural racism and also interpersonal racism, which still exists certainly. At Healthcare for the Homeless program, we have built a structure of not only integrated by primary care and behavioral health in order to better meet the needs of our patients, but we've also, of course, integrated addiction medicine services. We provide medication for opioid use disorder to more than 600 patients across more than 30 sites in our practice. We have committed ourselves as well to recognizing that we have to go to our patients rather than expecting them to come to us. And we've built low threshold spaces for individuals who are at different levels of readiness in terms of quitting substance use, some of whom actually are not ready and may never be ready to quit substance use, but we're there for them to make sure that we eliminate or we reduce harm as much as we can. We are just incredibly, incredibly grateful to be at the table for this and hope to continue to be at the table for the city's efforts and the commission's efforts moving forward with this grant funding for all of the innovative programming and equitable designs that we can put in place. So thank you very much.
Thank you.
Thank you so much for allowing me to be here. I'm Dr. Charles Anderson. I'm the President and CEO of the Demick Center. Special thanks to you, Congresswoman, for your hard work in making this opportunity available for us. It's timely, it's important. Thank you, Mayor Wu. Thank you, Dr. Ojikudo. Thank you for all of your leadership in helping us really seize this moment and address these opportunities that are in front of us. I'd also like to thank you from the onset of doing this in this real realm of positivity. The reality is we're looking at this, which a lot of people say are just too big to solve. And it's your kind of relentless energy that helps remind us that we can solve these problems. They are solvable. Solutions are about an active process. It's not a noun, it's really a verb. It's how we come together actively and do this. And this funding is part of the fuel that supports that engine to drive solutions. And I thank you for that. At the Demick Center, we actually are a federally qualified community health center. We serve over 20,000 residents. We're on a 9-acre campus right in the middle of Roxbury. On our campus, what we've done in terms of substance use disorder is that 30% of the non-hospital detox beds for the city are on our campus. So we've got 39 beds going to 44 soon, and we do about 2,000 admissions a year through our detox. But it just doesn't stop at detox, because once someone goes through detox, there's other stages of that process. This is a chronic disease that can be managed, but you can't do it in a fragmented system. Right? If you have detox somewhere, you have next steps other places around the state, it makes it more difficult. So what we've actually done at the Demick Center is we offer detox, step down, which is clinical stabilization, and residential recovery. Well, what does that mean? It means someone like a patient I was talking to yesterday who spent 9 months on our campus is able to start her process in detox, and 9 months later she's able to exit our campus with a sense of hope, a job, although she corrected me, she doesn't have a job, she has a career now, which she never thought she'd have. She has housing, and she has this sense that she knows that there are people who care about her and that her life does have meaning. That's what we do by actually bringing all these services together on one amazing campus, serving hundreds of people every single month on their journey. I should also point out, which is really important on this in this process, is that we are clearly seeing this intersection of unhoused, increased mental health, and substance use disorder coming all together to the point that traditional models for caring for individuals are having to change. We're looking at it from the standpoint of the people that are part of that.
That was an endorsement.
We're looking at it from the standpoint of the people who are required in terms of that change. There's lots of data to support the fact that when you have racial and ethnic concordance between provider and patient, there's a different level of satisfaction. And when you really talk to patients and clients in this setting, what you realize very clearly is there are things that they're able to talk about in that situation that they aren't able to talk about with someone who does not look like them. So it's about how do we actually continue to bring more people in who represent the community that we serve, and we're actively doing that. Number two is about process. And process is this. We have a way that we think about supporting people in terms of mental health and substance use disorder, and we talk about things that are trauma-informed. There's a significant trauma associated with just being black or brown in America. We need to make sure that that's part of our process as well. When we're talking to individuals who are trying to make their way through and to get through this journey, if we're not comfortable having a conversation about how racism impacts mental health, then we're not serving the needs of a large group of individuals where that is a big part of the issue. So we're introducing that in our programming. And the other one is around infrastructure. So we're constantly thinking about ways to add capacity, because one of the challenges here is, do we have enough capacity? Again, 30% of the non-hospital beds on our campus, that's 39 beds. There are roughly 5,000 people in the state, roughly 1,000 people, there are 50,000 people in the state, roughly 5,000 people in the city of Boston who are looking for services every year. We need to be adding capacity. We need to add capacity in communities where there are individuals who want to receive services in their community because that's where they feel safe and protected. So those are the things that we look forward to partnering and continue to partner with you on in terms of things that we do at the Academic Center.
Thank you. This is really an extraordinary table. And I thank all of you for lending your expertise, but moreover, really bringing your full heart to this work each and every day. I want to start with a broad question, and then I'll get to a more granular one that I'll direct to the commissioner. But when I at first ventured sort of into this space legislatively around anti-racism in public health, the response by many, very well-meaning, colleagues, allies, advocates in this space, I think it's hard for people to not respond in a way that is defensive. So if you do the work of recovery and substance use disorder treatment, if you are a doctor, if you are a dedicated staff member at a shelter, supporting those that are unhoused and sort of congregant, in a congregant situation, the response was often, but I'm not racist, right? I'm very committed to my clients. I'm very committed to the work that we're doing every day. I'm not racist. And I just wonder if you could speak a little bit to that, because we know that a lot of this is, well, all of it is about social determinants, right? In the Massachusetts 7th, in a 3-mile radius from Cambridge to Roxbury, Harvard Square to Nubian Square, life expectancy drops by 30 years. Now that is not something that organically happened in the ether. That is as a consequence of what I would consider to be policy violence and budgets that don't codify the value, of every life, and communities that have been under-resourced but disproportionately burdened by environmental injustices, perhaps unequal access to quality health care, residing in subpar housing, which we know housing is a critical determinant of health, and then, of course, the impact of racism itself. And so this is about those with multiple marginalized identities experiencing layered, sometimes legislated trauma, and how we respond in this moment. So For those who don't, and you all have done an eloquent job already, but I wonder if you would just double down on, and whoever would like to speak to, how does structural racism show up? Is it just about training doctors? Is it just about a staff that is reflective of the community with which you're serving? You know, how do we do that in this space? And actually, Commissioner, I'll start with you, because this grant is a novel concept, which in and of itself is saying something, right? So because this grant is specific to addressing issues with an anti-racism lens. So that's new. And so I know we're in the early process as Commissioner of executing on this grant, but could you share your guiding principles in applying for and executing this grant?
So I think a lot of people, when they think about how we deal with the issues that have been so well described, they take a racial equity lens. And I think that's a good thing, but let's delve in and let's talk about what that means. For most people, what that means is having a very disciplined approach to how we're documenting race and ethnicity, knowing who it is, who's getting access to what, you know, at what point they're getting access to what do their outcomes look like, understanding the disparities, you know, and maybe, you know, working to fix them. So that's a racial equity lens. What we want is a racial justice lens. And I think that delves more deeply into what racism does. It means addressing the trauma that Dr. Anderson mentions and having that woven into any intervention that we try to implement. It also means shifting power. It means the people who are living with the problem need to be at the table addressing, designing, developing, and, you know, studying the solutions. I think that is where you dig into how you address racism, particularly as you address structural racism. Who's developing the policies? How is it that we are truly engaging them? Are we doing it in an equitable way so that not only do they sit at the table, because I know I just used that term and we all use that term, but are their voices being heard? And are their voices then involved in the actual implementing of the intervention? So for me, that's the difference between, you know, looking at race and ethnicity and really addressing racism.
Very well put, and I so appreciate your distinguishing a racial equity lens from a racial justice lens. Thank you for that. Dr. Anderson and all of our healthcare partners, I'm going to ask a question and then we'll follow up with the mayor. Dr. Anderson, you and I have been spending a fair amount of time together through community project funding, working cooperatively with those closest to the pain. We were able to deliver a $1 million investment to DEMIC to support that program and invest in that, which you were speaking about. And one of the data points that I found most alarming was that during the pandemic, we've seen a 69% increase in opioid fatality of Black men. And so, as I said at the outset, we know that every disparity has been exacerbated. Wonder if our partners in healthcare would just speak to how has that shown up, specific to substance use disorder and homelessness. Yeah. How have you seen, what sort of trends are you seeing, and how have disparities been compounded? What are you seeing on the front line?
I'll also tie that to your first question about how do you deal with someone who says, I'm not racist. And I think about the young people often say, it's, you know, don't hate the player, hate the game. Mm-hmm. It's not about the player. It's about the system and the game, right? So I think it's really important that we're not talking about individuals who are racist. We're talking about a structure and a system, right, that discriminates against those in a way that interferes with one's ability to access the services in a way that everyone else is able to access and benefit from them. When we think about the 69% increase in death rate for Black men during the pandemic as an example, we tie that to the criminalization of substance use disorder, which wasn't necessarily thought of as substance use disorder, but thought of as addiction, and then thought of as criminals. And we think about the increase in incarceration over 3 years from 50,000 people to 400,000, and many of those being individuals who are of color, Black and brown, who actually were incarcerated related to nonviolent drug offenses. After a while, you see that, and you feel that, and it makes it really, really hard for a Black man who's just trying to care for his family, but in dealing with all the other things that he's dealing with in life, finds himself in this path of trying to self-medicate and deal with the mental health challenges that his system isn't able to help him deal with. But he can't raise his hand because if he does, he's going to immediately be thought of as a criminal. Right? He's going to immediately be thought of as an addict. Substance use disorder doesn't apply to him. So what does he do? He uses in isolation. One of the things I learned from our clients all the time is that heroin's not the problem anymore. You can't find heroin. It's fentanyl. The problem with fentanyl is that it'll kill you. Especially do that in isolation, shuts down the system. The young lady I talked to yesterday, for example, the main reason why she came into treatment is because she realized doing this in isolation because the stigma and not being able to raise her hand like anyone else was going to lead her to be in a position where she was going to die and die alone. So we got to understand these structures that impact the way someone views themselves and views the way a system will care for them does interfere with one's ability to access
care. Thank you, Doctor.
Which then leads to the outcomes we're seeing.
Thank you. Which does beg a larger question, I think, as well, in terms of do we find distinctions in treating BIPOC communities with men and women, which I would love to unpack that. But before we do, because I know we have about 5 minutes, and I want to be able to have an even greater equality of voices around the table. But Mayor, I'm going to turn it over to you because I'm curious about how you would distill your approach to addressing homelessness through existing city resources, and where do you see, other avenues to partner, but sort of what's your guiding principle and frame here?
Well, I think in some ways it's challenging to distill because homelessness is the symptom, not the problem. Mm-hmm. And so all of our efforts around how we plan and permit development in our city, how we're investing in schools and youth development, it really all is the actual solution. But in terms of how we've been particularly thinking about, again, led by Dr. Ojukutu and Chief Dillon and our housing cabinet and others across the team, Jen and everyone who is here today, it's really, we have to get to root causes. And so you heard some of the numbers about hundreds of people served through our housing surge. Prior to January of this year, the city of Boston did not have any low threshold, fully medically supported housing units that we could directly connect residents unhoused at Mass and Cass to. And in being able to stand up about 200 of those units, we've seen remarkable success for individuals who are able to access these units and the services. It's been transformational. 72 people now, not only served by this housing, but then transitioning on to permanent housing with jobs and careers, with services, with rent resources to help with that. Of the individuals who are in those housing units now, I think a couple statistics I want to lift up. More than 80% have a housing plan in place, working with case management and coaches, and 60% have even identified a way to pay for rent once they identify an apartment and housing. Nearly 2/3 are regularly receiving primary care treatment now to address health issues, the comorbidities and others. Half receiving medication for opioid use, and almost 1/3 receiving mental health services. And these numbers, compared to what is possible when someone is living on the street and very, very hard to make it on a regular basis with transportation and everything else to your scheduled appointment, to see the ability to take care of all those pieces of your humanity at once is what unlocks kind of the next step in that journey. Now, of course, the challenge for Boston is that we are a center city and the service city in a regional and national crisis here. And so we continue to say we've now had 10 months of being able to document exactly what works and how much it works and how transformational it is. And we need to do it even more, and to, as has been said by some of our partners, to have this sited in locations that are accessible to all, and in places across the state where people can more easily travel to them.
Thank you. I know that we have to transition to the presser shortly, but Wendy, since it's important to all of us to center those closest to the pain who've been the most directly impacted, your story is certainly an inspiring one, and we're grateful for all the lives that you're changing and saving now. Do you want to speak a little bit about sort of what you're seeing now and how we can best support the work that you do and the communities you serve?
So one of the things that we're doing at MGH is also looking at a racial equity and racial justice lens. And part of that work is inviting the community and looking at communities. I live in Mattapan, and I always say Mattapan's kind of a desert between Mattapan and Hyde Park. There aren't even like peer-to-peer meetings, for recovery there. And so one of the things that we're looking at is really looking at the different kind of hot spots in Boston and where there's a lot of substance use. We know Mass Ave, but there's also Fields Corner, there's also Mattapan Square, there's also, Dorchester Ave. And so there are a lot of places in the city where people of color are living and congregating, and there's no services. And so one of the things that we're looking at is, what does our recovery coach team look like? And we're hoping, we're looking at hiring coaches who are from those areas. Since I've started there, we've hired at least 3 coaches of color who live in the area, and we know that having a coach of color really works and really gets to let people have the wall down even easier. So when I was coaching, once people would meet me and they say, "Oh my God, thank God you're black," other black people, and I say yes, and I would tell them my story and share about my story and share that I'm from Mattapan and this is what I'm doing, and it inspires hope. And so if we can have more people who are in recovery, more black men, we need so many more black men who are recovery coaches and trained as recovery coaches, because recovery coaching is so near and dear to my heart, and I really, really believe that is the gap. That's where the gap is. It's, after treatment and still having that support. Where can I still find the support? Where can I still find, somebody who understands what I'm going through? And that is a really important piece that I think has been missing in this process. And recovery coaching is still fairly kind of new, but in Massachusetts we're training coaches. I was telling Dr. That we are making sure that our coaches also have a racial equity lens, and what are they doing to look at themselves and look at their biases, and how can they be advocates in the places that they're working.
Excellent. Thank you. Would either of you like to have a final word?
I just want to underscore again from the Healthcare for the Homeless perspective how fantastic it is to be at the table with such esteemed not only colleagues but also with you all as leaders, and also to highlight that within the homelessness space, and again this intersection of addiction and substance use disorder, we know that there has been a racist war on drugs. We know that has bled into and has deeply impacted the care or the individuals who we see on the streets today. It is part of the fabric of why they're there. And so we want to be at the table, continue to be at the table with this innovation, with increasing, advocating for increased workforce diversity, increased investments in recovery coaching, in behavioral health supports, in connections to care upon release from prisons and jails, which is a really, really vulnerable time for individuals who are experiencing homelessness when they're released. We have stood up some programming around correctional linkages to care, mobile health vans, et cetera, but it's not enough. It is definitely not enough. And so we welcome the opportunity again to continue to collaborate with the city, with you all, and are so grateful for the amount of support through this grant that is being funneled into, again, highlighting and lifting up this important public health crisis. So I want to thank you.
Thank you. And I'm very proud of the fact that in the Massachusetts 7, several of our municipalities did declare structural racism as a public health crisis. Boston, Cambridge, and Somerville, respectively. Dr. Congresswoman.
Thank you again, Congresswoman. I wanted to just pick up on a theme here about workforce development, that the addiction workforce is severely inadequate to meet the needs, and in particular, there is not nearly enough Black, Indigenous, and people of color in the addiction treatment workforce. Mm-hmm. So at BMC, we've been leading a collaborative effort to apply for funds that are becoming available from the state through HHS that are focused specifically on workforce development, and we're collaborating with 29 different addiction treatment provider organizations to fund internships for trainees in the addiction workforce. So social workers, recovery coaches, harm reduction, psychologists, et cetera, with a specific emphasis on recruiting trainees who are themselves Black, Indigenous, and people of color. So we're very excited about that opportunity, and it's really such an honor to collaborate with many of our neighbors on just doing everything we can to strengthen the workforce and help to address these both individual and structural challenges.
Thank you. Well, thank you all for meeting the moment. You know, we find ourselves managing and navigating these layered, unprecedented challenges, and I thank you for meeting the moment with unprecedented compassion and leadership and investment, and also collaboration. And, you know, I'm just so grateful to have you all as partners in the work of changing and saving lives every day. That's what we all want to do. So we'll transition now to the press conference and give them a moment to physically set the room, and then I hope you'll join us. Thank you, everyone. Thank you. And the mayor has a hard stop, so we're going to just let her take off. Oh, okay, for the convention, okay. All right, I know free. I should come with you. Let me think about it. Find out. Yeah. All right, any questions?
I'm wondering, as there's some predictions about, a red wave coming up after the election, your thoughts on working in a Congress, particularly trying to deal with structural racism and how it intersects with public health, how that may work and how challenging that can be after the elections, if the House, for instance, there's Republican and there's many more,
Well, Dr. Anderson did reference my, for lack of a better phrasing, optimism bias about all things. And I have that same optimism when it comes to our chances for the midterms. I think President Biden, in his remarks yesterday, really made it plain to the American people exactly what is at stake. And I'm of the belief that Democrats win when Democrats deliver. And we've been doing that, either with the passage of the CHIPS legislation, the Inflation Reduction Act, and certainly with the student debt relief, an effort that I led in the House working closely with Senator Warren. When people can tangibly feel the impact of our advocacy and of our policies. And I think also people are very clear that abortion care, which is health care, our reproductive freedom and bodily autonomy, and the very preservation and integrity of our democracy are all on the ballot. And I think that is made that much more plain when people see the threats to our democracy and to our lives with political violence and the like, what happens in the hands of far-right extremists, insurrectionists, and conspiracy theorists. So I think President Biden made it very clear what's at stake here. I think the Dems have a good story to tell, and I'm working hard for the next 5 days, locally and nationally, to ensure that we do keep the House and grow our majority in the Senate so we can abolish the filibuster and continue to do this work on behalf of the American people. Any other on-topic questions relative to the grant?
Can I ask another? Okay, yeah. I just want to be clear. Is the bulk of the grant going to expand on the work being done at Aspen Press, or is it more citywide?
Sure. Thank you for that question. So the bulk of the funding is for the city of Boston. We obviously have a concentrated crisis occurring in the Mass and Cass area. And as you all well know, we have approximately 200 people who are aggregated there per day. And we're certainly looking for any opportunity to help them move into housing, this low threshold housing that I mentioned, and to move on to recovery. But what we plan to do, which I think is critically important, is getting out into other communities, because there's certainly people who are living with and experiencing substance use disorder and unsheltered status in other neighborhoods all throughout Boston. So we have community engagement teams that we've established who are working with both community members as well as business leaders, decreasing stigma that's very prevalent in regards to substance use, incorporating their concerns and their desires into where we think about, additional low threshold housing should go. So we're really planning on using this as a citywide initiative.
Any other on-topic or off-topic questions? All right, I feel like I'm at a wedding, hearing none. Okay, thank you, everyone. Oh, I'm sorry, Ricardo is here.
I have a couple off-topic questions, but I was just going to wait until after because I didn't want to interrupt the press conference. Is that okay?
For you.
I can find you on the side.
Okay.
That way everyone doesn't have
All right,
to
no
stand
problem.
still.
Okay. Yeah. All right, thank you, everyone. Thank you
all.
so much. Thank you so much.
So good meeting you.
Oh my goodness, each of you is just such an inspiration. So powerful. I learned so much. You all have really just
Thank you, as
fortified me
always.
in this
As
work.
always, I want to get a
Yeah.
good picture.
Okay.